Hello, I'm Charles Haskell, medical oncologist, ethicist, teacher, and photographer. Welcome to my vlog where I tell stories that have informed my life. Today's story is about how I became a clinical ethicist. In 1968, my wife and I were living in Maryland where I was doing cancer research at the National Cancer Institute. My job at the NCI was to keep patients alive as long as humanly possible. That summer, we visited her grandparents in Switzerland. We were impressed that her elderly grandfather was still able to walk to the village every day. Shortly thereafter, he suffered a severe stroke and was put to bed in his chalet. After consulting with their doctor, my wife's grandmother decided not to admit her husband, Arnold Wierston, to the local hospital for treatment. Instead, the family kept him home for his final illness. I was pressed into action as the nighttime attendant so Christine's grandmother could get some sleep. Arnold lived about 10 days, during which time he received no food, no medications, no IV fluids. In fact, none of the procedures to prolong life that I employed at the Cancer Institute were used for his care. For years thereafter, I had an unsettling feeling that perhaps I should have done more to prolong his life. I believe the seeds of my interest in clinical ethics were planted at Arnold's bedside. Those seeds were later watered by sermons about ethics by the Reverend Ernie Pipes at the UU Church in Santa Monica, and by my experiences treating cancer patients at UCLA and the VA. In the early 1990s, I was asked to help resolve clinical ethical dilemmas at the bedside at the West Los Angeles VA between clinical staff, patients, and their families. The two most common requests dealt with the discontinuation of life support in the ICU and questions of informed consent before research or surgical procedures. I realized I needed a systematic approach for dealing with these life and death issues, so I developed a protocol for conducting ethics consultations that drew heavily on the work of the late Albert Janssen, an ethicist at UC San Francisco and the University of Washington. Janssen recommended analyzing ethical issues according to 5 principles. 1. Autonomy. 2. Beneficence. 3. Non-maleficence, otherwise known as the Hippocratic Oath of first do no harm. 4. Social context and laws. And 5. Patient and family preferences. The second principle, beneficence, can be broken down further into treatment given with curative intent and treatment of palliative intent. Doing an ethical analysis of Arnold's final illness might go like this. 1. Patient autonomy. He was unconscious and had no living will or its equivalent, so the substituted judgment of his wife was appropriate. 2. Beneficence. There is no cure for a severe stroke that is several hours old. Comfort measures were the only real option. IV fluids might have added a few days to his survival, but meaningful prolongation of life was not possible. 3. Non-maleficence. Almost anything we might have done to prolong life would have caused him pain and discomfort, so treatment was limited to comfort measures. 4. Social and legal context. The family was respected by their community for the humane way they cared for Arnold at home. There were no social or legal constraints on how he was cared for. 5. Family preferences. These were clearly followed. He was allowed to die quietly at home. This kind of ethical analysis has helped me come to terms with what we did and didn't do, in 1968 from my wife's Swiss grandfather. This experience has also helped launch my career as a clinical ethicist. This completes my story about how I became a clinical ethicist. Thanks for watching. Goodbye.